Inside the human body lies a closed-loop transport architecture composed of over 60,000 miles of pressurized tubing. It is responsible for continuous gas exchange, nutrient delivery, and deploying rapid immunological defenses to any injury site within seconds. To execute these simultaneous tasks, the system requires a highly specialized liquid matrix. We call this connective tissue blood. When clinicians need to analyze this matrix, they place a sample into a centrifuge and spin it at thousands of revolutions per minute. The immense gravitational force separates the fluid into its distinct physical components based on density. This chart shows the resulting breakdown. The lighter top layer is plasma, which constitutes 55% of total blood volume. It is a straw-colored viscous fluid, acting as the primary solvent, because 90 to 92% of it is pure water. Suspended within that water is an 8% payload of heavily engineered hepatic proteins. Albumin maintains colloidal osmotic pressure, keeping the water inside the vessels instead of leaking into surrounding tissues. Globulins act as the defensive arm, synthesizing antibodies. And fibrinogen provides the raw materials for the coagulation cascade to seal vascular breaches. In clinical diagnostics, removing fibrinogen and all other clotting factors from a plasma sample leaves behind a distinct yellow fluid. This remaining liquid, utterly incapable of clotting, is defined as serum. The remaining 45% of blood volume consists of the formed elements. These are the physical cellular components: erythrocytes, leukocytes, and thrombocytes. The vast majority are erythrocytes, or red blood cells. Mammalian erythrocytes undergo a brutal evolutionary adaptation. As they mature in the bone marrow, they actively eject their own nucleus and internal organelles. By discarding its control center, the cell collapses into a biconcave disc. This shape maximizes surface area and hollows out the entire internal volume to pack in massive quantities of hemoglobin, an iron-rich pigment built exclusively to bind and haul oxygen. Erythrocytes also discard their mitochondria. Without the organelle required for aerobic respiration, red blood cells rely entirely on anaerobic metabolism to survive. They are forced to operate without consuming the very oxygen cargo they are delivering to the rest of the body. Stripped of their DNA and repair mechanisms, these cells have a hard limit. After exactly 120 days of continuous high-velocity circulation, the aging cells are routed to the spleen and dismantled. Sharing the fluid matrix are leukocytes, fully nucleated, colorless white blood cells like neutrophils that act as the system's phagocytic infantry, and thrombocytes, fragments of larger cells that trigger the fibrinogen webbing upon injury. The cellular components of blood operate as strictly engineered payloads, sacrificing standard cellular survival functions to achieve absolute efficiency in mass transport. Mixing blood between humans requires exact immunological matching. That compatibility is dictated by specific glycoprotein structures, or antigens, embedded directly on the surface of the red blood cells. This logic matrix maps out the ABO system. The governing rule is strict. An individual's blood plasma naturally produces defensive antibodies against whatever antigens are absent from their own cell surfaces. If you have antigen A, you carry anti-B antibodies. Type O cells lack both A and B antigens, meaning they trigger no immune alarm when transfused into others, making type O the universal donor. Conversely, individuals with type AB blood carry both antigens, meaning their plasma produces zero counterantibodies. They are universal recipients, able to accept any ABO blood type. A second highly dominant antigen governs compatibility. It is the Rh factor, carrying a name derived from the rhesus macaques, where the protein was first identified. You either possess this D antigen, making you Rh positive, or you lack it, making you Rh negative. This specific antigen creates a severe clinical threat, known as erythroblastosis fetalis. If an Rh negative mother carries an Rh positive fetus, the first pregnancy is usually safe. But during delivery, placental tearing exposes the mother's bloodstream to the fetal Rh positive cells. Her immune system recognizes the foreign protein and begins mass-producing targeted anti-Rh IgG antibodies. The danger strikes during a subsequent pregnancy. If the next fetus is also Rh positive, the mother's newly minted IgG antibodies are small enough to cross the placenta. They will actively swarm and destroy the fetal red blood cells in a massive hemolytic attack, causing severe anemia and jaundice in the womb. To prevent this, clinicians administer a specialized injection called RhoGAM to the mother immediately following the birth of the first Rh-positive child. The injection destroys any stray fetal antigens before the mother's immune system can sensitize to them. Bleeding off from this high-pressure arterial network is a secondary fluid system. As plasma leaks from the capillaries into tissues, it is gathered by lymphatic vessels. This fluid, now called lymph, is entirely colorless. It lacks red blood cells, operates at very low pressure, carries high concentrations of lymphocytes, and serves as the primary route for absorbing dietary fats from the intestines. A single missing surface protein can turn a life-saving transport fluid into a lethal immune trigger. Moving the viscous fluid matrix against the forces of gravity and peripheral resistance requires a specialized mechanical pump. The human heart is a muscular, mesodermally derived organ sitting in the thoracic cavity. Evolution has divided this pump into 4 distinct chambers, with a thick septal wall running down the center. This barrier ensures that oxygen-depleted blood returning from the body to the right side never mixes with the oxygen-rich blood returning from the lungs to the left side. Vertically, the architecture is specialized by force. The upper 2 atria possess relatively thin walls, functioning as passive receiving pools. The bottom 2 chambers are the ventricles, built with dense, massive myocardium required to forcefully eject blood out of the heart. This graph illustrates the double circulation pathway. The right ventricle pushes blood through a short, low-pressure circuit to the lungs for gas exchange. The left ventricle takes the returning oxygenated blood and drives it through the systemic circuit, forcing it out the aorta at high pressure to perfuse the entire body. By ensuring the systemic flow remains entirely uncontaminated by deoxygenated blood, the heart delivers oxygen at the peak concentrations required to fuel a warm-blooded metabolism. This structural segregation is the physiological foundation for the high energy demands and constant internal temperatures of mammalian life. Separating the upper atria from the lower ventricles are the atrioventricular or AV valves. The tricuspid on the right and the bicuspid on the left act as mechanical check valves, ensuring blood only flows in one direction. When the massive ventricular muscles contract, internal pressure spikes violently. This upward force threatens to blow the valve flaps backward, everting them into the atria and causing catastrophic backward flow. To prevent blowout, the valve flaps are tethered to the floor by fibrous cords called chordae tendineae. As blood surges upward, these strings whip taut. At the exact moment the ventricles contract, specialized papillary muscles protruding from the chamber floor also contract. They pull down on the chordae tendineae, applying countertension to lock the valve cusps firmly in place against the immense rising pressure. The heart maintains unidirectional flow by using these precision tensile structures to actively anchor the leaflets against the very forces attempting to drive them open. The timing of those muscle contractions requires exact coordination. The heart generates its own electrical action potentials, a property called myogenic automaticity, making the heartbeat entirely independent of external nerve stimuli. The primary generator is a patch of tissue in the upper right atrium called the sinoatrial or SA node. It functions as the natural pacemaker, firing the initial electrical spark that ripples across both atria, commanding them to contract simultaneously. The electrical wave hits the atrioventricular node and pauses. This built-in microsecond delay allows the upper chambers to fully empty their fluid into the ventricles below. The signal then shoots down the bundle of His and up through the Purkinje fibers, delivering the shock directly into the thick ventricular walls. That electrical spread dictates the mechanical timing of the cardiac cycle, which takes just 0.8 seconds to complete. It begins with 0.4 seconds of joint diastole, a resting state where blood passively fills all chambers. Then the SA node fires, initiating 0.1 seconds of atrial systole, to squeeze the final 30% of blood down into the ventricles. Next comes 0.3 seconds of ventricular systole. The lower chambers violently contract. The rising fluid pressure slams the AV valves shut. If you listen through a stethoscope, the abrupt snapping of those valves creates the first acoustic heart sound, a low, booming lub. Blood is forced out through the aorta and pulmonary arteries. As the ventricles finally relax and internal pressure drops, the blood attempts to fall back into the heart. This forces the upper semilunar valves to slam shut, creating the second, sharper sound, the dub. The brute mechanical force of the pump is entirely useless without the microsecond precision of its embedded electrical software. Because the body is mostly water and electrolytes, the heart's electrical cascade radiates outward to the skin, where it can be captured by an electrocardiograph. This split-screen graph maps the electrical potentials over time. The cycle begins with a small upward deflection called the P wave. It represents atrial depolarization, the exact electrical spark spreading from the SA node that triggers atrial contraction. Following the slight AV node delay, the graph spikes violently. This is the QRS complex. It represents ventricular depolarization. Because the electrical signal is tearing through the massive muscle bulk of the ventricles, the voltage spike is huge, immediately preceding their powerful mechanical contraction. Finally, the trace shows a broad dome called the T wave. This indicates ventricular repolarization, tracking the electrical reset of the lower muscle mass back to its resting state, ready for the next cycle. An ECG is a precise, millisecond by millisecond map of the heart's electromechanical blueprint in action. Identifying exactly how this integrated system fails is how clinicians separate symptoms from root causes. 3 common pathologies are routinely confused, but they strike entirely different components of the circulatory engine. A myocardial infarction, commonly known as a heart attack, is a plumbing failure. A coronary artery becomes physically blocked by plaque or a clot. Deprived of oxygenated blood flow, the localized muscle tissue undergoes rapid ischemia and dies. The pump still works, but its tissue is starving. Cardiac arrest is an electrical failure. The SA and AV node conduction pathway malfunctions, throwing the heart into a chaotic rhythm known as fibrillation. The muscle spasms uselessly. Pumping action drops to zero, and the patient collapses instantly. Heart failure is a chronic mechanical failure. Over time, due to hypertension or aging, the ventricular myocardium weakens or stiffens. The heart continues to beat, but it fails to generate sufficient cardiac output. Blood backs up, leading to fluid congestion in the lungs and extremities. True mastery of physiology lies not in memorizing anatomical parts, but in understanding how fluid dynamics, electrical pacing, and structural engineering succeed and fail as one unified engine.